Hi, welcome to this 33rd Congress International Medicina de Urgencia, and welcome to Mexico. I'm Dr. T.S. Srinath Kumar, Head and Group Coordinator for Department of Emergency Medicine, Narayana Hridayalaya, and also the Treasurer for International Federation of Emergency Medicine and the Academic Council Chair for Society for Emergency Medicine India. For the next 20 minutes, I've been assigned to talk about the action of emergency doctor in the face of the lethal intoxication, that is for the aluminium phosphide. We'll go with the case scenario. It's a very common uh, poison in our country, India. So, a 21-year-old female was presented to emergency department with an history of consumption of 3 tablets of pesticide. Probably it was white color and decided it is an alphas 6 hours back at her residence. She complained of nausea, multiple episodes of vomiting, and abdominal discomfort with breathlessness and discomfort. On arrival to emergency, her airway was not patent due to oral secretions. She was immediately intubated and secured with an endotracheal tube of size 7.5. And the breathing was about, saturation was 93% on room air. And you can see the circulation already. The patient has some symptoms of the aluminium phosphide. That is, the blood pressure is hypotension and the heart rate is tachycardia. So immediately she was started on noradrenaline, which is a vasopressor to be started after a bolus of 1 liter of ringalactate. Her disability was E3V5M6 at the arrival, but after intubation, she was E3VTM6. And her peripheral was showing the hypotension symptoms. With the systemic examination, now being drowsy, the CNS is drowsy and oriented, but the ABG started showing up the metabolic acidosis with the lactates of 6, which is very dangerous. And the bicarb is also started decreasing. The EKG showed sinus tachycardia. So we came to a diagnosis of acute aluminium phosphide, which is an extremely lethal poison because the aluminium phosphide per se, which gets releasing the phosphate gas when it comes in contact with moisture or with hydrochloric acid in the stomach. So that is what is the most dangerous thing, which we can see. It is usually seen as a dark gray tablets and available as sulfas or alphas, and it is usually foul odor smell to decaying fish or garlic. And it contains 56% of aluminium phosphide, the 44% of carbamate. So we know that either by ingestion or inhalation, it reacts by the hydrochloride to form the phosphine gas, and it is rapidly absorbed through the GI tract, and it causes the cardiac systemic toxicity, varying from cardiac arrhythmias to pulmonary edema. And if it is absorbed via the inhalation, it is converted from oxidase to oxyacid, and it is usually excreted either by urine or lungs. So the fatal dose, it can be a little bit of a 515 milligrams or anywhere range. So that is a problem. And when it is inhaled, even a little bit of inhalation is sufficient for to create a aluminium phosphide toxicity poison. So why this is very important, for why we have to know that it is important to know the pathophysiology, because it inhibits the cytochrome C and mitochondria and thereby the cellular respiration. So now we understood why the lactates is getting accumulated and the metabolic acidosis which is forming. It releases a highly reactive oxygen radicals, and it is very corrosive action on the mucous layer. And it also causes lipid peroxidation and cellular injury with reduction in the glutathione and the alveolar capillary membrane injury. With this background of the pathophysiology, we have to keep in our mind when you are treating the patient. And the main problems, this is the circle where the problems are seen. The toxic myocarditis, the severe systemic acidosis, distributive and cardiogenic shock, acute kidney injury, multi-organ failure. So all 5 things are seen in aluminium phosphide poison. And that is the reason why it is very lethal and it is very fatal in these patients. As I mentioned, even a little bit of inhalation, even less than 0.3 ppm is sufficient for starting the patient on the toxicity. And the clinical features, we know that when it is inhaled, it causes airway irritation and breathlessness. While it is taken inside through oral, it causes nausea, vomiting, diarrhea, headaches, abdominal discomfort, or pain. Then later on, going in for serious symptom, as I mentioned to you in those five pictures. So, what are the EKG changes? It can be just a sinus tachycardia, or it can go in for arrhythmias, fatal arrhythmias. Usually, within the 3 to 6 hours when they present, we see sinus tachycardia, and after 6 hours, the problem starts with the arrhythmias, that is the ST3 changes and the conduction defects. Varying arrhythmias, let it be VT, VF, whatever you say, you can see in these patients. But the main important thing, what we have to understand in this particular aluminum phosphide poisoning is its effect on the cardiac and the production of the arrhythmias, which is very, very dangerous. And what other arrhythmias in their poisoning? You can see the various, it can be TCA overdose or antipsychotics or OPC, that is organophosphorus compound, or you can see all the fatal things like a oleandrosid, which is again very, very common in our country, which can cause bradyarrhythmia. So these are the two various tachyarrhythmia causing poisons and bradyarrhythmia causing poisons. So when we think about this, and then immediately when we see these particular poisons, and you have to stabilize the patient and go according a protocol, then only you're going to treat the patient and you're making the patient to survive. So the most important problem in this is the refractory hypotension. The patient will be speaking to you, but when you check his blood pressure, it will be hypotension, and the mean arterial pressure is usually less than 50 or 40 millimeters of mercury. And it could be because mainly because of the peripheral vasodilatation, so that it gets accumulated. That is the reason why there is a distributed shock. And then because of the myocarditis or the cardiac involvement and the myocardial damage, that is the reason for the cardiogenic shock. So distributed shock as well as cardiogenic shock. The metabolic acidosis, we saw that there is a cellular metabolism which has been damaged, and the respiratory system is also damaged. Thereby, the alveolar system is damaged, causing metabolic acidosis and lactic acid accumulation. So, other uncommon findings which you may see are intravascular hemolysis, adrenal cortical insufficiency, hepatitis, acute tubular necrosis, pancreatitis, methylmaloninemia. You would mention everything you can see in aluminum phosphate poisoning. That is the reason why it is very, very lethal. And you have to be on your toes whenever you hear saying that there is a patient who has come with aluminum phosphate poisoning. Now, proceeding, the most important part, that is our emergency department management. So, please ensure that you're going to resuscitate the patient. Only when you resuscitate fast, the outcome is also fast. 99% of the patients whom I have seen have always succumbed and they die. The first and foremost thing, please, when you see the patient in hemodynamic instability, don't hesitate. Early intubation to prevent aspiration. That is the most important thing. And also, thereby, what it happens is it creates an adequate tissue perfusion by hydration. Adequate oxygenation is the main therapy in this particular patients. And before even you think that the patient is going in for hypotension, don't hesitate to start vasopressors. Even a slightest reduction in the blood pressure is an indication for you to start vasopressors. Take an ECG to look into the arrhythmias, accordingly treat the patient. ABG is a must. Look into the acidosis, lactates, creatinine, and also the bicarb levels. And then you start off with your regular procedure. Resuscitation should be followed by decontamination. That is the reason why emergency department has become very, very important, especially in the management of poisons, because only after resuscitating we start for decontamination. We don't start decontamination and then go for resuscitation, because when you do the decontamination, you cannot put an endotracheal tube or you cannot have the patient cure the swelling. So how do you decrease the exposure of poison? We did multiple tests. We tried with silver nitrate, we tried with potassium permanganate, we tried with coconut oil. Most important thing is, please don't use water directly, because when the water comes in contact with aluminum phosphide, immediately the phosphine gas is released, and thereby the cardiac arrhythmias will start. Already when the patient has taken, it acts with the hydrochloric acid and the problem starts. So that is the reason, whatever is left out, please do the gastric lavage judiciously using the potassium permanganate or coconut oil. Why coconut oil? You may ask me. Coconut oil will soothe it protects the stomach layer from mucosal danger and also further release of the hydrochloric acid. That is the reason. And then this particular coconut oil, when it mixes with the the aluminum phosphate, the effect of the aluminum phosphate is gradually reduced. That is the reason why you have to use coconut oil. So that will be useful for these patients. Hemodialysis, not much of useful. It it may be useful only when the patient is setting in with the renal failure or multi-organ failure, or a patient with metabolic acidosis which is not responding for a regulatory. That is the mainstay in the treatment is magnesium sulfate, which helps for the cellular membrane stabilization, reduces the arrhythmias because the arrhythmias can range from anything to everything. And then it also reduces the oxidative stress. And what is the dosage? The dosage is 3 grams infusion or 3 hours, followed by 6 grams over 24 hours for 3 to 5 days. That is what is the treatment protocol for the aluminium phosphate. Now, coming to most important thing, that is your management of the toxic myocarditis, distributed shock, a cardiogenic shock. Early vasopressors, as I mentioned, go with norepinephrine or dopamine. Norepinephrine is the most preferred drug to treat the hypotension, in particular these patients, and also it helps in the cardiogenic shock. Also, there's a wonderful drug called as glucose insulin potassium, jig magic, what we call it as. So any patients here, because of the insulin's effect on the myocardium, with the chronotropic effect. So that is the reason why insulin is particularly used in this particular scenario. And we all know the side effects of insulin is hypoglycemia and hypokalemia. So you add it up, you take an 100 ml of 25% extras, add 8 units of insulin, and then you can usually use 10 or 20 milliequivalents of potassium chloride and start it off directly. Over 4 hours, you see the magic what happens. It gradually improves the blood pressure. That is why JIC has become a very important drug in the management of the uh, aluminum phosphide poisoning, especially in the emergency department. And once they are not responding for these mechanisms, don't hesitate to start intra-arterial balloon pump therapy for these patients. And further, if the patient is not responding, then LVAD is the treatment, that is left ventricular assist devices are being used whenever you see a patient with severe myocardial depression, refractory hypertension, ERDS, or metabolic acidosis, which are very common with aluminum phosphide poisoning. And then ECMO is also a well-documented therapy for improving the survival of these patients. Let it be VV ECMO or VA ECMO. Both have shown some promising improvement of this short-term survival of adults with the aluminum phosphate poisoning, which is associated with LV dysfunction or severe metabolic acidosis or even refractory shock. So going forward, as we all know, there is no specific antidote for this particular agent. So it is better to avoid. And it can be, you can use multiple other drugs by the farmers apart from your aluminum phosphate. A legislative and administrative measure have been suggested to restrict and modify its supply across the globe. So hence, I request your country also to take this forward and try to bring in some legislative measures so that the usage of aluminum phosphide is reduced. Unfortunately, there has been a failure in this implementation. So that is the reason. And hundreds of cases have been seen. So we published a book on management of toxic patients, especially all the poisoning patients in our country. And you can see one of the associate editor was me. And when we did it, we mentioned one of the treatment protocol for the optimum management of aluminum phosphate poisoning in case of an emergency department. In the emergency department, you can see the first and foremost important thing is your airway, breathing, circulation, stabilization. And only then, if you want, if once your patient is with your control, then only start for the take the patient for the decontamination. And mind you, no water, only coconut oil or potassium permanganate, followed by multi-dose activated charcoal, which again acts as a agent which will not further absorb. It acts as an absorbent, so it will not allow for the absorption of the aluminum phosphide. ABG and lactates must be checked thoroughly, and according to the protocol, you have to treat it. The patient is having metabolic acidosis, you can straight away give sodium bicarbonate 100 cc, and then it can be followed by 50 cc or continuously for the next 24 to 48 hours. And then CRRT is one of the mainstay treatment here. So you can go ahead with this. And if the patient is having hypotension, cardiogenic shock, LV dysfunction, you please go ahead with your glucose, insulin, potassium therapy. And if the patient is not responding to this, then you further take the patient to IABP or left ventricular assist device, which is very, very important. The key points from my side is only three things. Try to avoid and advise your farmers not to take aluminum phosphide, which is very, very lethal. Try to bring in a legislature to ban this particular agent. Second point, if you see these patients, use only coconut oil or potassium permanganate. Third is elective intubation. These are the three things which we have to keep in our mind. So thank you all. If any further questions are there, I'm ready to take it.